Good afternoon, everybody. Welcome to Leukaemia Care's advocacy webinar and what can Leukaemia Care advocates do for leukemia patients. For all of those of you who haven't joined us, first of all, thanks for joining us. If you'd like to ask questions, please can you post them in the chat box, and these will be picked up and they will get to me and I will address them to our panel. It's a great pleasure today. I'm Nick York. I'm Patient Advocacy Healthcare Liaison Officer, part of Leukaemia Care's advocacy team, and it's a terrific pleasure today to be on the panel with my fellow advocates, Charlotte and Ella. Before I hand over to Ella to introduce herself, we're also live on Facebook. If you're on Facebook and you want to drop a question to us, one of my colleagues is monitoring Facebook and will pick up any questions if you enter them below the video in the comments box, and then they'll get to me and we'll field those time permitting. So just from a process point of view, Ella will introduce herself and tell you a little bit about herself and what she does within the advocacy team for Leukaemia Care, and then hand over to Charlotte. Charlotte will do the same, and then Charlotte's going to give you a brief, or maybe not so brief, overview talk of the practicalities in day-to-day advocacy, because obviously it's a long journey for many of us, and that takes us from diagnosis right the way through different stages in the pathway, and there's different aspects of advocacy delivery and practical aspects where Leukaemia Care advocates can get involved to help you. And then after that session we'll have a question and answers discussion, and that's where we need your input. So if you've got specific questions, drop them in the chat at any time, they'll be picked up. One thing I do have to say though, that we're going to try and address all the different aspects of advocacy. So there's the practical, how we can work with you to help address any advocacy issues you've got with regards to your care, access to treatment, etc. And then there's other aspects of advocacy that are a bit broader in terms of influencing policy, access, campaigning, some of the mystical elements that my good colleague Ella will also touch on. So on that note, unfortunately, we're unable to address individual advocacy inquiries you may have in this webinar. At the end, I'll be putting up some slides that will give you email addresses and phone numbers so that you can then field those to us in the advocacy team. So without further ado, it's a great pleasure to have you all join us and to introduce Ella. And Ella, please tell everybody who you are, what you do, and a little bit about yourself.
Good afternoon, everyone. My name's Ella, and I joined Leukaemia Care about 6 months ago as the advocacy officer. So my role includes doing individual patient advocacy, as well as some of the stuff we do with HTAs, which is our process, the process for approving new drugs on the NHS. We're involved in that as well. And then also the campaigning and policy side of things, which Nick touched on. So yes, I sort of do a range of different things, but we'll come on to that a bit later about how they all feed in together. Yeah, it's a pleasure to be here today and excited to talk about more about what we do.
Cool. Thank you, Ella. And I think that leads nicely to myself. So I'm the patient advocacy manager. Those of you who attend webinars in the past will know my face from hosting these. So I'm pleased to pass over to Nick on this occasion and actually be able to speak. Hopefully my presentation, even if it's not brief, will be interesting to all of you. I'm just going to sort of explain a bit about what advocacy is. We've used the word several times already during the webinar, but I'm conscious that it's not a concept that's familiar to everyone. So hopefully by the end of my presentation, more will become clear. Oh, we need to go back a couple of slides. There we go. So I was looking initially when I was making this presentation earlier today about definitions of advocacy that's sort of floating around on the internet, which some of you may have looked at if you were like, oh, I'm not sure whether to sign up to this webinar, I don't know what it is, and you may have looked it up to see whether it was of interest to you. And there were a couple of dictionary definitions that come up. The first of which is an activity or by an individual or group, that aims to influence decisions within political, economic and social institutions. So basically an activity that attempts to influence a decision maker of some kind. And then of course there's the idea of a professional advocacy as well, which is not something we do within the advocacy team. So I think these two were not very helpful to actually what we wanted to talk about today. So I hope that the next slide will sort of clarify what we mean by advocacy and what advocacy can mean in the context of sort of charity work. And I found this definition from Citizens Advice, which I think is much more helpful. And it's taking action to help people say what they want, secure their rights, represent their interests, and obtain services they need. And actually, we do this, as has already been alluded to by Nick and Ella, on two levels. One is by supporting an individual. So, we're here to listen and we're here to empathise as a charity, but we also are keen to help you find a solution to the problems that you're facing. And I think that's an additional step that not every charity has the capacity to be able to do. We're very pleased to say that we are able to do it through our advocacy officer, Ella. However, the other thing we do is take that, again, as has already been alluded to, and use what we know about the problems that people are facing to enact change on the wider scale. And Ella will say much more about that later. In this part of the presentation, I'm going to focus purely on supporting an individual and help clarify the sorts of things we can support with. Oh, well, there we go. I put a little animation in there to make that point. So what does this actually mean in practice? So an advocate is someone that can listen to your views and concerns. So sometimes it's just useful to be able to put everything you are concerned about on the table, to be able to see it all in the light of day, if you like. Sometimes we have conversations with ourselves in our head, and not all of us feel comfortable sharing the burden of our worries with friends and family. Sometimes it's nice just to have an independent person to relay all that information to listen to you, and perhaps participate in the decision, but not always. Sometimes it's just useful to put the views on the table. An advocate can help you explore your options and rights. So there are certain things as a patient that you are entitled to. There are certain things that you can expect as best practice, which we'll come back to later. And there are certain things that certain times in which you need to make decisions. And again, sometimes it can be difficult to visualize those yourself. And an advocate is there to help you explore all the variety of options. To provide extra information. So in an ideal world, everybody would be given all the information they possibly need at the first conversation with their doctor about a topic. But I don't think that happens in every occasion, and we're here to help you find the additional information you need to be able to make decisions or raise concerns. The next thing is to help you contact relevant people, contact them on your behalf. And the obvious example is to make a complaint, which we'll come back to later. But there are other reasons why you need to get people involved in a situation, but you may not feel comfortable doing it yourself. And we're there to support you through that process. And accompany you and support you in meetings and appointments. Now, we're a small team of two and in the individual casework side, and we're not able to always do this, but we can support you to find someone in your local area who can do it, or do it virtually where we can. There are loads of options of what we can do. And what all this made me think in terms of actually applying it to leukemia was the word uncertainty. So the purpose of an advocate is to help you find your way through what is an inherent uncertain situation, receiving a diagnosis of leukemia, or making a decision about the best treatment for you. All of the examples I'm about to give have a common theme of not the person making the decision not always knowing what the right decision is for them, and then you place the advocate in that situation, so Ella or myself or possibly Nick on occasion, and helping you to work to weigh up pros and cons and work out what decision is best for you and relieve that uncertainty as much as we can. I think some of the examples we're going to give later in the webinar are examples of where we didn't know the answer, particularly around COVID. And I think it's important to say that as advocates, we can reassure you in letting you know that what you don't know is what we also don't know, and you're not missing anything. You haven't missed some big news about vaccine efficacy in leukemia patients. Sometimes not knowing and being reassured that you're not the only one who doesn't know is also as equally as valuable as being able to come to a final decision. I hope that makes sense. I think it was important to relay what an advocate generally will not do. And we're not there to provide a personal opinion. We'll sort of take all the information you give us and we may summarize or provide some analysis to help you come to a conclusion, but we'd never give you a personal opinion. Excuse me, sorry, talking too fast. We'd never it says solve problem, make decisions for you. I guess we can sometimes present you with a solution that we feel meets all the criteria that you've shared with us, but we'd never insist that's what you do or make that decision on your behalf. And we'd never judge you for having these worries or concerns. We're here to be non-judgmental and to listen and to help you evaluate the situation that you're in. So, just to clarify before I sort of give a few more specific examples of where this is actually helpful in your leukemia journey, if you like, or pathway, or however you'd like to describe it. I just wanted to clarify the difference between the advocacy officer and our welfare officer, who isn't able to be with us today. I guess the welfare officer largely deals with sort of benefits, debt, housing, employment, anything to do with finances, whereas any questions you have related to your care and your treatment sort of fall more onto the advocacy side. And today we're going to focus on the advocacy officer role rather than the welfare officer role, just because finances is a whole other area of webinar topics that we could do. In fact, we could probably do 5 or 6 with the sorts of things our welfare officer can help you with. So just for brevity, we'll focus on the advocacy side for today. And it's important to note that we're not sort of replacing medical advice, including our own nurse on the helpline. We very much work with them and also with the wider services team. So in the course of perhaps discussing a problem, if we think you may benefit from some of the other services we provide, such as the counselling fund, such as being put in touch with someone who has similar experience to you through the buddy scheme, we'll always sort of make that suggestion to you as well and put you in touch with the services team. So we're very much a part of a wider team, but just to clarify sort of the scope of today's conversation. So who can we help? I also wanted to point out that we don't just help patients or don't just have to help patients. In fact, quite a few of the people we help are family and friends of patients. Obviously, as the person going through treatment for leukemia or a diagnosis of leukemia, you probably are the one most likely to get all of the information. And especially during COVID, family and friends can often feel like they're getting information third or fourth hand. And we're more than happy to take questions or have discussions with people, with family and friends of a patient as well. We can also work with employers and other key workers. I think some of the really interesting cases I've been involved in have been where there are other people who just need to know a little bit more about leukemia to enable them to help the patient as well. So I think it's important to point out that you don't have to approach us yourself. If you feel like others in your life will benefit from having a discussion with the team, please do put them forward towards us as well. So how can we actually help? So the point of diagnosis is probably one of the scariest points for a patient. And here there's a variety of ways we can help if you are concerned. If you think you've experienced a delay to your diagnosis, whether or not you want to do anything with that information, we can sort of chat you through what the usual process of diagnosis is, discuss whether you have experienced any issues along the way, and if so, whether you want to take that forward into either a discussion with your haematologist about whether that was a problem or not, or whether you want to make a complaint about that. We can sort of sit down. We'd be more than happy to sit down and sort of explore what's happened up to diagnosis and help you understand what's happened to you so far. Another thing we can do is understanding next steps and looking for more information. So if you're coming out of a sort of your initial few appointments with the haematology team, you may feel that you've had a lot of information thrown at you and you're not quite sure how to process it. And even if it's a case of us sort of repeating or rephrasing some of the things the haematology team has said, that's what we're here for, is to sort of help you process that information in the way that's best for you, that you may not have time to do so with in the constraints of a medical appointment. One of the things we often get asked is how the health system works. So your rights, and I think we'll touch on this a little bit later with some of the real practical examples we've got. What are your rights to certain things? How often should you be seen by a doctor? Should you have access to a clinical nurse specialist? All these sorts of questions are things that we can give you information on and support you to get what you need if you are not getting what you need. And then how and what to share with others. So if you don't know whether you should be telling your employer, your insurance company, the DVLA, and just the first government organisation that came to my head, I'm not sure why. But if you want to know what you need to do as a result of diagnosis, or what you should do, or what you could do, which are all very different things, we'd be more than happy to sort of talk you through that process. One stage that applies to many leukemia types, but not all, is active monitoring or watch and wait, where you don't immediately need treatment following diagnosis. And again, we can talk to you about whether you are accessing all the support you're entitled to and help you find out how to get hold of it if not. So for example, CLL patients placed on watch and wait are some of the least likely to be offered a clinical nurse specialist. And if you feel that you need that support, we'd be more than happy to work with you to find out if that's something you can access in your local area, to name one example. So we can help you with problems across healthcare teams. So for example, some people are monitored by their GP as well as their haematologist, or in addition, instead of their haematologist, sorry. And that can cause some issues on occasion, not always, but it can. And if you're having trouble sort of resolving those communication problems, we can sort of talk you through who is best and how best to express those concerns. And I think that covers my third point as well. And then we come to the pre-treatment stage. Whether you've been in active monitoring or not, there will be a short period of time pre-treatment where you need to consider what treatment is and what treatment do I have? And I have spent considerable time with people in the past weighing up the pros and cons of treatment and what's important to you, and therefore helping them to come to a decision without telling them which treatment is best. It sort of inevitably happens over time as you explore various pros and cons. And the same with clinical trials. If you're thinking about a clinical trial, there's another layer of uncertainty to consider there, often more tests and things like that. So we can do the same for clinical trials. If you're unsure whether you should be involved in your treatment decision, whether you feel as if your healthcare team has given you all the information you need, we can explore that with you. And we can also talk you through why a specific treatment has not been put on the table. There are various reasons why treatments might not be considered. They may not be approved, they may not be available in the NHS, they may not be suitable for you for physical reasons, for genetic reasons. If you're unsure about any of these things, we can talk you through them. During treatment, what I often find from people is during treatment is they say, I'm concerned about this, so a side effect, or something that appears to be going wrong in their opinion, and they're not quite sure who they should tell. So we can point you in the right direction of who you should be talking to. Again, it can be difficult to keep family in the loop, particularly if you're an inpatient. So we can help bridge those communication gaps and bring everybody together. And also, especially during COVID, there's been questions about visitors and whether people can have visitors and what are their rights to visitors. And that's just one example. We can touch on that a little bit later too. Another example we thought of in advance was around end of life. If you're approaching your end of your life, you've run out of treatment options, or otherwise it's sometimes called a terminal diagnosis, although the length of time that you are in a terminal diagnosis can vary. We can talk to you about what your rights are to care, what sort of support is available out there. And also, similar to treatment, but we can help you weigh up the pros and cons of having treatment. At this stage, the patient is often given quite a lot more freedom about whether they want to continue treatment or not. And sometimes that can be a really hard decision to make. And sometimes you want to bring family and friends in on that decision. And we'd be more than happy to sort of talk you through the pros and cons of that. And then there's bereavement. So I guess there's two sides of bereavement that I wanted to point out. One is what support is available. What should I be entitled to when I'm bereaved? We can talk you through sort of employment rights and things like that. But one of the most common questions we get is, I'm not sure I've understood how we've got to the point where my loved one has unfortunately passed away, and I'd like to ask these questions of the haematology team or of the palliative care team. How do I raise those concerns? And we can connect you up to the right people in order to do that. And I believe, not quite the end of my presentation. So we can deep dive into some of those specific examples and what we would advise generally in those examples in later discussions with me, Ella and Nick. I wanted to point out that there are certain types of statutory advocacy that we can't do. So if you're receiving care or are detained under the Mental Health Act, you're legally entitled to an advocate with special training, and we're not able to provide that kind of service. Also, if you are deemed to be mentally incapable of making decisions for yourself for whatever reason, I think the classic example of this is a dementia patient, you are also legally entitled to an advocate. And there are also certain people who, this one's a bit more complicated, who are entitled to a social care advocate. So we aren't able to perform any of these functions at present. We just don't have the training. But what we can do is we can support these other advocates to understand your leukemia diagnosis and or its treatment and its effects if necessary. And I have done that for people on occasion who have other advocates. I just wanted to put that one out there. Oh, and we're back to the beginning again. So thank you to everyone for listening. I hope that has helped clarify what individual advocacy is and why we do it and what we can do to help, and happy to take any questions.
Thank you, Charlotte. You've covered a great amount of ground there, and that was a bit of a whistle-stop tour all the way through. I think there are a couple of questions came in actually whilst you were talking, and I think one of those was quite a really interesting and pertinent one. Somebody's just dropped a line. Sorry, I can't see you at the moment. I apologise. My right eye is not playing up too well, and I've just dropped my large screen. So if I'm a bit slow responding sometime, everyone on the panel and audience, please give me a little bit of leeway. Yeah, it was about patient confidentiality. You know, when representing patients or disclosure issues, I'm assuming the question that thank you for raising that question is, what are you bound by from a patient confidentiality point of view? To what level can you act on behalf of the patient, I'm guessing, and where are the boundaries when it comes to disclosure?
So we'd never share anything externally with anyone without the patient's express permission, usually in writing by email. In terms of, I think the crux of the question is whether patients would want certain things shared with their friends, family, or employers. And I think if we know who the patient is, but the patient hasn't given us express permission to share stuff with the family or friends, that the family or friends haven't explicitly said that they already know, we wouldn't share that. It's important that we don't inadvertently share things. If we don't know who the patient is, and the family or friend has come to us independently of the patient, and I don't see there being any problems there, because we can only work on the information that the family or friend has provided us. And we would always make it clear that we're working on the information they provided us, and if any of it is not accurate, because we don't have direct contact with the patient, you know, that becomes a limitation to what we can do. But in essence, we would never share anything with anyone without express permission of the patient. I hope that answers the question.
I think you've covered that, and I'll wait to see a response from our person in the audience. Thanks very much for that question. I guess what I wanted to do, if I could, was just maybe mine a bit deeper than on some of the topics you were talking about, you know, that you just whistle stopped through.
Yeah.
And one of the areas was around how can advocates help with understanding, helping somebody understand how their care is provided and how the decisions are reached. And somebody's asked a question about who they should be talking to and how they can reach the right people. So I was just wondering if it's possible for you to explain that. And that question that comes with it is, what is an MDT and what is a key worker? Is that the same person as a CNS? You know, from that point of view, the question relating to is who is the best person that somebody should be talking to when it comes to understanding how their care is provided if they're having problems in that area?
Sure. So I think just broadly, who the best person should be talking to depends on what the problem is to some extent. But if we're talking specifically about care in hospitals, which I know Ella can expand on a little bit, there are several key players. So the MDT is the multidisciplinary team, I think is what it stands for, but it's basically a team of a variety of professionals in the hospital that come together to discuss particular cases. And I guess it's a way of ensuring best practice, that hematologists aren't making consultants aren't making decisions sort of in isolation. The pressure isn't on them to make the right decision. They only have expertise in certain areas. The consultant is an expert in sort of the treatment of leukemia, but the CNS, the clinical nurse specialist, is more an expert in the day-to-day care of a patient. And then there could be people like physiotherapists and fatigue experts, and there can be a variety of people involved, but the whole idea is to bring expertise together. So they may have contributed to the decision a consultant has relayed, but the consultant may not have explained that to you. So it's always worth just sort of having a conversation with hematologists about, can you just explain to me how you've come to that decision? And then they may bring up the MDT at that point. And most hematologists I know would be more than happy to explain to a patient how they have come to a decision. And then a key worker is usually the person that you have been asked by your hospital to use as your point of contact. And they usually are the best person to go to in the first instance, unless, of course, you've got concerns about that person, in which case we'd help you figure out how to express those concerns without necessarily talking to the key worker if you don't want to. I think I've covered everything there.
I'm sorry to stay with you for the moment, Charlotte. I'm just looking at questions that have come up when addressing issues. You mentioned in diagnosis, addressing early diagnosis problems or diagnosis delays. And I'm just wondering, picking your depth of knowledge, really, you know, the NHS Constitution, and are there specific pledges related to cancer care? How much depth of knowledge do advocates require in this area, and do you act on that yourself? Is that part of your knowledge, or are you working with other people when addressing issues in this area?
Most of this information is online, actually, and I found that a massive resource as an advocate. Obviously, you know these things as you become a more experienced advocate, but I think one of the benefits that we can do as advocates is to do the somewhat arduous task sometimes of doing the Googling, filtering the results to what's relevant, what's factually correct, what's a reliable source, and then passing that on to the patient. I think sometimes the research is possibly the worst bit. That's just my opinion. Others may disagree. In terms of specific pledges or things that you have a right to, in terms of cancer, there is the 2-week wait pathway. So essentially, if a GP suspects you have cancer, unless it's a acute leukemia where they are advised to send you to the hospital same day, you are, if you're suspected that you have cancer, you have a right to be seen within 2 weeks by the specialism of the cancer you are suspected to have. So bowel cancer specialist if you have bowel cancer, leukemia specialist if you have leukemia, or may have leukemia. So yeah, you should be seen within 2 weeks. And if that's not the case, you should.
Is that just England?
I believe that's just England. I think they have a very similar system in Wales, and Scotland eludes me. Apologies, but if anybody needs to know that, please do drop us an email and we can find the specifics. I don't have my notes in front of me. I did write it down, but when you're in the flow, you do forget these things. So more than happy to find that out for somebody if necessary. But Wales has a similar pathway, although I don't think it's exactly 2 weeks. I think it may even be 21 days.
Okay. So I'm going to let you off the hook in a minute and bring Ella in, but
that's okay.
a bit of a segue there in terms of, I suppose it's relevant. I mean, how how can you help, and where is the information and advice to questions with regards to helping patients understanding what are expected standards of care? In other words, what are rights, who are nice, and how important are nice recommendations, for example, and where do clinical guidelines fit in all of this practice? I guess this all relates if somebody's got dissatisfaction with their care or complaints, and they want to understand that they are understanding the right care.
Yeah. It doesn't always have to come from a complaint. Sometimes it's just sort of nice to get a bit of reassurance that you're receiving the care you should be. You don't necessarily need to suspect there's a problem in the first place. But Ella will go on to the complaint section, I guess, in a moment. But in terms of what you're entitled to, there are lots of words floating around, as you've alluded to, Nick, that aren't quite the same thing. So rights are laid down in the NHS Constitution, which you can actually read online, and it sets out rights and responsibilities for patients and the public. And one of those is the 2-week wait in England that I've already alluded to, but I think there's a few others around which hospital you can go to, and those sorts of things. But the rights are fairly limited within the NHS Constitution. Then there's the next sort of thing doctors would use to decide specifically what treatment you're entitled to would be MHRA approvals. That's the Medicines and Healthcare Regulatory Agency. So they say a treatment is safe to use. And then NICE if you're in England, SMC if you're in Scotland, which are 2 acronyms that I won't bother saying, but they're basically 2 bodies that decide whether a treatment is cost effective for use on the NHS. And we could do a whole other webinar on what cost effectiveness is and what NICE is and things. But essentially, if something is approved by those organisations, and they usually define the patient population in which a treatment can be used as well as the treatment. If you are in the population that they have specified a treatment should be used for, then you have then it can be used on the NHS. But importantly, it doesn't mean you have a right to access it. The next thing that comes in is clinical guidelines, where clinicians will discuss between them and publish best practice on which treatment is better. So there are taking first line treatment, so the very first treatment you get after diagnosis as one example. There may be 3 or 4 different treatments that are approved for the initial treatment of a particular leukemia type. So how does one decide between those 3 or 4? That's where clinical guidelines come in. And then best practice is also used as a bit of a term outside of official written down guidelines, where doctors talk with each other. They have conferences, the papers are published on a regular basis. basically there's always loads of conversations going on in the clinical community as to what is the best way forward for each group of patients, rarely on an individual level, but usually quite small patient groups, you know, particular genetic mutations, particular physical characteristics like other diseases that are affecting them, diabetes and heart disease and that sort of thing. So there's a lot of information sharing going around. And I guess the crux of this is, if you are not sure how a decision has been come to, we can help you discuss all the different factors. So what's NICE approved, what is approved by the MHRA, but don't be afraid to ask your haematologist. They probably will be more than happy to share what the basis of their decision is. And I hope that's helpful.
Well, it is. I think I've just got a couple of questions. There's a kind of segue question there that we can grab early on that somebody's asked. And there's another one from an inclusive point of view. You mentioned NICE being England and SMC Scotland, but I think from an inclusive point of view, NICE also provide the guidance for Wales. Northern Ireland, they tend to follow advice between the two from whatever the Scottish is and what NICE is that right?
My understanding for Northern Ireland is that they will accept NICE recommendations, and if they're unable to, for cost reasons, they'll publish that decision online. But in the vast majority of cases, they just take up the NICE recommendations.
I think maybe this is something we can touch on at the end with regards to other areas of advocacy, because
absolutely,
others on this call are involved in those areas of pressing for access for patients and representing patients. Yeah. But when you were talking about different types of treatment and different recommendations, somebody did post a question about how can they go about getting a second opinion if they're seeking access to a latest treatment. I'm in your team and I'm not sure which one of you two to focus that question to. So does either one of you want to grab that? How can somebody go about, I know from personal experience that there are NHS websites that show you what your rights are, but actually the process of obtaining a second opinion, how can somebody go about that when they're actually seeking access to a drug that might be NICE approved and available, but that's not being offered to them?
Yeah. I mean, Ella, did you want to give this one a go?
I will have a go, but please feel free to fill in the gaps if I miss anything. So I think my understanding is there's several things you can do. I think you can either go back to your GP where you initially got referred and get referred again to a different consultant. I think that would be if you were changing consultants though, which is probably slightly different from getting a second opinion. Alternatively, you can, I mean, we can definitely help in that situation. I've helped before, and we can research sort of experts or particular people that might know more about your situation, and give you the contact details of those people. And it's possible to arrange, I think there's different options privately and also on the NHS, but there's various different options you can go down in terms of trying to get a sort of sit down meeting with them.
Yeah, that's all correct.
If the treatment not available in routine commissioning, that would also possibly involve on behalf of patient, working with the patient to explore clinical trial availability or other routes to access.
Yeah, that's right. Yeah, we can help with that too.
I think the one thing I would add, sorry, Nick, to what Ella has said in terms of rights is there's no specific right to a second opinion. It's a case of going back and requesting it, but in my experience, 3 years of many cases now, the very few doctors, haematologists or GPs, will refuse a second opinion upon explanation of what the second opinion is for. And actually very few haematologists are offended by being asked for a second opinion, particularly if it's to explore treatment, which is the topic of the question that's been asked. But just to also clarify, by the wording of the question, a second opinion does not guarantee a different outcome. So the person's asked, can you help if you get a second opinion to access to a new targeted treatment? The second opinion doesn't change, one, what's available on the NHS and what's approved for use, that won't change, and two, it doesn't guarantee a change in the clinical decision making. The second person may come to the same conclusion, and you have no right to sort of insist on a particular treatment. It's the doctor who, is the clinical decision maker here. So I just wanted to clarify that based on sort of the way the question was asked is all.
Thanks for that. That's where you've rescued my eyesight. My large screen's down, so I didn't pick up all of that, and it flashed across the screen. So thank you very much for that really interesting question. Ella, I guess we've been talking about raising concerns if you've got issues around your hospital care, and what the Leukaemia Care can do and what we provide to help with understanding of that area. Are you able to explain a little bit more around what are recommended processes if you've got concerns, and how you can raise those, and if there are informal aspects, or if there are, and the difference between informal and formal, and actually raising complaints, or even if you have to then take it beyond the initial complaint, how you work with patients, and how, from experience, if you've got any examples without disclosing specifics of individuals of how you're able to work together with patients?
Yeah, of course. Yeah, I can give you an overview. So obviously it depends on the concern that the patient has, the level of that concern, and also, how long it's been going on for. And we'd recommend perhaps different things depending on, all those factors. But I think to start with, to touch on the sort of informal side of things, I would often recommend that the patients speak to the person that is relevant in the situation. So the hospital care team, if they feel able to, that could be consultant or nurses, or if it's a question about diagnosis or an issue about diagnosis, then maybe the GP is the most relevant person to speak to. But often sort of having those informal conversations and can help to sort of clarify things in the quickest way possible, and also then prevent kind of further escalation of the issue. And you can do that, in regular appointments if you feel that's suitable, or most patients should have contact details of whether it's, as I said, consultant or their secretary, or the relevant people should be able to get in touch with them and have a conversation about it. So it's very possible to do that informally, and I think that's definitely a good starting point with raising issues and complaints. Although complaints then segues into the sort of slightly more formal approach. Just before I touch on that, there is, as an advocacy officer, I can, if someone is wanting to sort of speak to relevant members of their healthcare team, then sort of struggling to know how to do that or who to go to, I can definitely help provide some advice in that situation, whether it's just, being able to articulate clearly what it is that you want to ask or say, or again, as I said, who to direct it to. And I think Charlotte mentioned earlier, but we can also help to liaise with some of the healthcare team if you're struggling to find those points of contact. And then moving on, just to mention, this is for informal as well as formal complaints, but every hospital has a service called PALS, which I'm sure lots of patients are aware of. PALS stands for Patient Advice and Liaison Service. Each hospital has a separate PALS team, but PALS are the department whose role it is to sort of resolve any concerns between a patient and the healthcare team. And you can go to them for advice as well, and they can help sort of be that team on the ground that helps facilitate that communication. So they can do that for informal things like I just spoke about, as well as more formal complaints. And then moving on to more serious complaints, things that might have been going on for quite a long time, or things that have a more serious nature. You can write formal complaints through the hospital. So each hospital has a different complaints procedure, and you can find out about those usually online if you type in the hospital that you're at and then the complaints procedure. It's usually fairly easy to find. Again, if you have struggles, if you have issues knowing how to do that, or struggles with that, then we can help you find out who the relevant people are. But you can follow that formal complaints procedure, and we can support with that. You can also formally write a letter to your consultant, or again, whoever it is that's relevant for the particular issue. And PALS can help with that process as well. And yeah, as I said, the different hospitals do have different complaints procedures, and naturally it depends on the nature of your complaint as well. But there are some rights that patients have across the board when it comes to complaints. So I'll just touch on some of those as well, so everyone's clear. The first one is probably self-explanatory, but that every patient has the right to make a complaint about NHS services, and if you've experienced issues with any part of your treatment care that you feel doesn't meet the expected standard of care, then you have the right to raise that complaint. Typically, the complaint should be acknowledged by the NHS within 3 working days, I think. They won't respond within that time, very unlikely, but they will at least acknowledge that you've made the complaint. And then you have the right to kind of discuss with PALS or whoever it is the manner in which the complaint is being handled, how long it might take, whether there's any updates, progress, that type of thing, and to be informed as to the whole process and the outcomes that happen.
An interjection there that's come from a
Yes.
patient and somebody in the audience. I think it's Ross, you've shared that with everybody. We're talking about scenarios where things are broken down, where we obviously don't want them to get to. And bearing in mind that the most important thing for a patient is the doctor-patient relationship, and you're building that relationship of trust over time. Yeah. And it's a really interesting and valid question from Ross. Is it not difficult at times for a patient to raise a complaint without feeling as if they are potentially breaking a trust or a bond with a doctor or the medical team? And that's part of the reason where dissatisfied patients, or you're in a situation where you haven't been understood or something isn't right for you, but you don't know how to raise that. So being a devil's advocate on behalf of our person in the audience there, you're contacted by a patient who's dissatisfied about the situation but doesn't want to break that bond. And if you're living with a chronic condition or even an acute condition, you really need to trust in that relationship between each other. And I'll throw this at both of you really. How do you help somebody overcome that and address that situation? Can you liaise, arbitrate, or are there stages to this process?
I think obviously, again, it depends on the nature of the concern, but I think it is important to be able to, as you say, have that relationship with your doctor and then open those lines of communication as well. So if there is something you're experiencing that you're concerned about, to share that with them in a sort of more informal manner and be able to discuss your options, and hopefully they can then provide some reassurance or some alternatives. But being able to sort of open those lines of communication informally is often just as important as being able to do it formally. Charlotte might have some more advice on more formal complaints with regards to that.
I think for me, the thing I see quite a lot of is people coming and saying, I don't feel like this question has been answered in my most recent telephone appointment, which I really understand that must be really frustrating. I'm just using this as a common example. And the first thing I tend to say is, have you considered writing down your questions and sending them by email? And sometimes it sounds really silly, it sounds really simple, and it sounds a little bit patronizing, but I think it's quite difficult as a human being, and putting myself in the consultant's shoes or the clinical nurse specialist shoes, is to understand the gravity of those concerns unless it's written down plain as day in front of you. And I think that's one of the easiest ways to salvage a relation or keep a relationship without going straight to a formal complaint, is to do that informal stuff that Ella has said. And it genuinely, most people who come to us aren't at the complaint stage yet. They're at the I have this initial frustration stage, and there is a step in between, and that step can be really important. And on the arbitration point, it's not something we've had to do, but it's something we could do, or help find someone in. I've helped a person in the past find a local advocacy service. We're not the only ones who do health advocacy. I found her a local person who could attend the appointment alongside her to interject if her questions were not being answered, whilst I was providing that advocate with the information they needed to know when the question wasn't being answered. So obviously, as a small team, we can only do so much, but we can support others to be empowered to independently support you. And even just a friend or family member may be able to play that role, actually. If you don't feel confident speaking up because you want to maintain your trusting relationship, take someone else who doesn't matter if they're the ones who speak up. That's the whole point of advocacy, is to not be afraid. As the advocate is the one who isn't really afraid to rock the boat because it doesn't affect a personal relationship.
Yeah,
I hope that helps.
The other thing I would just add is that consultants and healthcare teams are there to help people. And if there's something that you feel that they're not doing or that they could have done differently, it's likely that it's not going to be necessarily an accusatory thing. It might just be a case of, okay, well, we need to think about this and work better together. And it's not, it's sometimes things that they're open to discussing. It's not necessarily a sort of pointing fingers, but it's more about just coming to an agreement where you can sit down, have a chat, and then move on in the best way possible for both parties. So, usually they can be quite receptive to feedback and complaints as well.
Yeah, the problem often comes when you come to us too late and you're at the complaint stage. Do come earlier. Come when you're first worried. That's what I'd say.
They're both really interesting feedback, and I'll sort of really reflect on that in another area. It kind of joins up with what we were saying about getting second opinions and the Constitution, and understanding the value of your relationship and how to communicate and how to navigate to avoid those situations. But if things do break down, I know we talked earlier, answering the question about getting second opinions when it comes to access to a therapy. But on the same topic, things are broken down. You're not happy necessarily with the only option you have for your local consultant or your local doctor. You feel there's an impasse. Are you, either of you, up to date with current constitutional rights with regards to accessing alternative care? I seem to recall some years back when I was in that area that within NHS England, as long as you could fuel or fund yourself to get to the other locations for care, then but could you elaborate a little bit in that area in terms of what are your rights around accessing second opinions for your care or for alternative care if you're not happy with what you're having locally and you feel you can't get past that impasse? Or if you feel you might get better care elsewhere or more specialised care elsewhere?
Yeah, they want me to take this one. My understanding is at present that it's not a right under the Constitution. It's a case of something you can request. I mean, you have a right to request it. I don't think it's a case of you have a right to it, if that makes sense. It's a very slight difference. But again, in my experience, like you say, Nick, as long as you can get yourself to the place where the other consultant or nurse or whoever it is, and they have the capacity to take you on as a patient, which again, I've helped. Off the top of my head, 10 or 20 people do this, and not once as another consultant said, no, I can't take you on. It's extremely rare. And sometimes part of the problem is the waiting period. And so obviously if you're going, whether you ask your haematology department to refer you to a different haematology department, or whether you're asking your GP to refer you to a different haematology department, inevitably going to be a time lapse. And I always make sure people consider the time lapse and whether if there's an acute illness involved, whether that's a sensible thing to be doing. And yeah, always good to have that in the back of your mind. Okay,
and I'll just finish on that one then. Patients are educated, we're educated to believe that those with access to specialist consultants achieve better outcomes. And if somebody wants to get referral to a specialist, although the haematology department or the haematologist will have good working knowledge or will be, how do they go about getting a referral should they want a referral? Who do they ask? Do they ask their GP? Do they ask their consultant that they don't want to put whose nose out of joint? I know most consultants, when you ask them that question, yeah, sure, I'd be happy for one of my colleagues to give you but is there a particular route? Somebody's also raised a question which is quite close to that, which is, sort of when dealing with a GP, if the GP has got zero knowledge about a disease, for example, CLL, because they can't be specialists in everything, and they might only see one CLL patient every few years, yeah, that the GP is being pestered by the patient, and then the GP is then pestering the consultant, or it could be the other way around, that the GP doesn't have sufficient knowledge. And I've had GPs myself as a patient have overreacted to situations when they've seen blood counts come through and started contacting the consultant for hospital admission, for example. Yeah. So coming back to my question, I think it was.
Shall I take the bit about the final bit on second opinions?
Our audience's question, which is thank you for your question.
Yeah. And I'll let Ella do the GP surgery bit, because I know you had some tips for making a complaint. It'd be good to hear if that's any different for a GP surgery, I think. But just to finish on the second opinion thing and moving a referral to a specialist, regardless of who the second consultant you want to see is, regardless of why you're going to see them, the process is the same. You need a referral from somewhere else, be that a hematologist that you're already seeing or a general practitioner. And I think that's a good summary of what we've discussed so far, to be honest. It's same process, regardless of where you want to go. You need to get a referral from somebody.
You have to get the referral. That's great. Thanks for that clarification.
And Ella, I'll leave the GP stuff to Ella.
Well, I don't know that I've got a sort of straightforward answer or resolution, but I sort of appreciate that can be difficult. And as Nick said, it is, GPs are general practitioners and they don't therefore see, many cases usually of a particular disease. I think, it's always in their best interest to make sure that they are then making the proper referrals. So I can understand that they'd be conscious to do that. If you did want to make a complaint about a GP surgery, you can do so similarly with the hospital complaints by, on finding the GP's website and their formal complaints process. But yeah, I think it's definitely a difficult one. I'm not sure that there is a clean-cut answer, really.
Yeah, it's a difficult one that all patients will deal with at some point.
Yeah. And
it's also a very difficult one when, we're having a complaints-based conversation here. But, ultimately, it's about building relationships and having that opportunity. And at the moment, GPs are so overstretched and they have narrow knowledge. But thanks for some.
Yeah, just another thing I was in, again, we'll touch on this more later, so I'll just say it really briefly, is that we're often, aware, and it's really helpful to have patients actually tell us about these issues in a different angle, in the sense that we can then think about how we might want to kind of lobby or do policy or campaigns for change. And so, GP education and things like that is something that Nick and myself and Charlotte work on from that point of view as well. So it is an issue that we're aware of within our wider work, but we can talk about that all a bit later as well. Sorry to jump the gun a bit there, Nick.
No, that's fine. I think the issue is also different potentially between chronic and acute issues.
Yeah.
Acute, will there be a need for speed because there needs to be an intervention or an action to actually make sure that there's an improvement. Whereas in a chronic situation, there may not be the need for speed, and there's the opportunity then to develop a relationship and help empower both parties. And that's part of the problem then, is the communication between secondary care and primary care. How can the advocates help to liaise between the two so that one is not pestering the other unnecessarily, and the communication lines can be opened up for the person's care? So it's a really valid question. Thank you for raising that. I'm kind of moving on through some of the questions, and one of the ones that's come up was when we were talking about second opinions for alternative treatment options. And so that's kind of led me into an interesting question that's, that we've received, which is, what happens if you're no longer able to access available NHS treatments? What are the other routes and routes to possibilities? I know the independent funding requests in terms of accessing clinical trials. How do you find clinical trials? And what are the pros and cons of private and self-funding situations? And how can advocates help with that process. I know
Yeah.
that's something we come across quite often in situations that could be considered terminal, or if people have run out of options and can't access what's available. There's nothing available through routine commissioning.
Yeah. So I've already sort of touched on the NHS options already. So just as a quick reminder, because I know it's quite technical, there is a body that decides which treatments are cost effective for use on the NHS. That is a thing that is a side effect, if you like, of our health system being taxpayer funded. Broadly, it works. I mean, we get access to the treatment we need. There's occasions where we don't, and Ella will touch on how we deal with that later on a sort of policy level. But if you as an individual do not understand what treatment options are available to you as a result, I guess there are two main options, really. One is look for a clinical trial of a new treatment option, or a clinical trial where the comparator arm, the treatment that the new drug is being compared against, is also favourable to you. That is a reason to go into a trial as well. And there is a website that's really good, but quite difficult to use if you don't have sort of some medical background knowledge, clinicaltrials.gov. And we often do searches for patients on there and filter out the results for them, where it lists basically most of the clinical trials are open across the entire world. You can filter by UK, and then you can look at what the entry criteria for the trial is and whether it's relevant for you. And we can never provide medical advice. We can never say definitely you will get onto this trial, but based on the information that you provide us, we can certainly filter down options and provide you with a list of things to go to your doctor with to say, are these relevant to me? And as I said earlier, searching for yourself can be quite an arduous process. The other way of doing it is to find other ways of funding. So there is a process in the NHS called individual funding requests, but these are used in very, very exceptional circumstances to gain access to a treatment for an individual, and the doctor has to apply to the local NHS board for that funding. It's quite an arduous process, and it has to be a truly exceptional circumstances, and you have to be the only patient in whom that is an appropriate option, which is extremely difficult to prove. The other options you've alluded to around self-funding, I would always caution people when considering self-funding options. You can crowdfund and fundraise the money for your treatment yourself, but it's very difficult to know how much money you will need. And the same sort of applies for if you're funding it out of your own pocket. So there are lots of complicated rules about if you buy your treatment privately, what is then covered on the NHS. So none of your side effect treatments are covered by the NHS then. And it's quite a complicated process. So there's actually quite a bit of research that I would recommend and that we can assist with if you are considering going down that route. And obviously, if you do want to fund a treatment, you are then paying what's known as the list prices in the publicly known price for a drug, which for some new drugs can be tens of thousands of pounds. So definitely something to get advice from, and what we're here to help you weigh up the pros and cons of doing.
Are there advantages to travelling abroad? Or negatives, positives? What other? Somebody's raised that question.
The advantages of going abroad is obviously we're a fairly small nation. I mean, we're quite ahead of the curve in terms of life sciences. Don't get me wrong, we pull our weight in the clinical trial space, but by far the biggest clinical trial runner is the US, and we get a few people asking if it's worth going to the US. It's been complicated a lot by COVID and travel restrictions and things like that. There are visas to consider. There's what to consider, like what if you get really unwell whilst you're having treatment, and whether the cost of that is covered. All the money involved in the travel and bringing someone with you, because you probably don't want to go alone. It's really something I would spend a lot of time helping someone consider all the pros and cons involved, but can get you access to treatments that aren't available anywhere else.
Thanks for that, Charlotte.
Okay.
Well, you've just mentioned the elephant in the room, haven't you, really? COVID. And
we were never going to get through it without a mention of COVID, were we?
and let's face it, it has presented so many barriers for patients, so many barriers for healthcare professionals, and limitations. And I know how busy we've been as advocates, and I know how concerned and the negative impacts on all of our patients, and continuity of care and a multitude of things. So I'm just wondering, Ella, if we could, maybe if you'd be able to share some sort of information in terms of what could you share a range of how the advocacy service, in terms of the advocacy group, of the sort of issues that we as an advocacy team and you as an advocacy officer have had to deal with during the pandemic, types of issues, and where you feel there are areas that you can still help. I think because we've been in this situation as patients, I'll talk as a patient, not just as an advocate, and it's ongoing and evolving. And it's a lot of people have had it up to here and are unable to cope with lots of areas, from emotional, psychological, access to care, access to routine care. Could you share what kind of work you've been having to do, and how you've been supporting the patient community and patients, and how you still can with topics?
Yeah, of course. Yeah. Yeah, so as you've just alluded to, and obviously it's, everyone's probably aware, the nature of our advocacy queries have changed a lot over the last 2 years nearly now, year and a half or so. And I think it's probably no surprise to many of you, but a lot of the queries recently around vaccine deployment, whether it's third jabs or booster jabs, and the issues that surrounded the third jab rollout in particular for the immunosuppressed. Yes, it was far from ideal, I think, and I think there's still ongoing issues, although I'm glad to see, I think that now they're saying 7 in 10 have, so 70% who are eligible for their third vaccine have now got it, which is good. But we were helping throughout that time answer questions, and there was also, I think there was a miscommunication with the advice that was given by sort of NHS from the top, and how that filtered down. I think it took a long time for people to realise what that advice was and to put it into practice. And so there was a letter that we were able to share with some patients, who were then able to share that with their GPs. And I think in some cases we had some success stories of that letter being really useful. So yeah, things like that, we helped in that regard. And just to note that if anyone who thinks they're eligible for the third jab and is still hasn't got it, or is worried about anything with regards to third jab or booster jabs, then do get in touch. It's helpful for us to know where the issues still are and what we can do to help and learn from them. And then also, hopefully we can have some kind of a discussion with NHS to provide that information for them as well. So sorry, I'll stop talking about vaccines now. But yeah, other things include antibody.
On that question, haven't you? Because
I know I'm opening a can of opening a can of worms with that one. Other questions include about antibody testing and whether patients are able to get antibody tests privately or on some trials and studies that are being done. What antibody tests are able to tell them, and how they can use that information. So we've had questions about those. As you said, Nick, there's been, for some people, delays to their routine appointments, especially I think in the chronic leukemias, and delays to blood test results and things like that. And again, it's just, I think we can help in several different ways depending on what's required, but one of them can be trying to liaise with the healthcare team, make sure that you can enable that communication with them, and hopefully work out a sort of time frame of when you might be able to get another appointment or receive those blood test results. And then just general advice about shielding and precautions, I think, and that's ongoing as well. There's not loads that we can do to sort of solve the issue of is COVID, but in terms of providing advice and reassurance, I think as well, and some sort of tips precautions that people can take that might make them feel more comfortable and help them to come to their own risk evaluation themselves. So that's some of the advice that we can provide as well. Yeah, I hope that's given you a flavour of the types of stuff in the pandemic. That's not everything, it's not exclusive.
You've thrown one up for me actually that I wanted to ask you myself, because I don't work in that area, which was during the peak of pandemic and hospitalizations. When we say peak, we were talking about level of infection in the community, and those that were immune compromised, acute patients going into isolation for transplants, and those that are inpatients, and the isolation they were experiencing with no family attendance. Obviously the levels in the community are as high as they were then, and if you're going through those therapies, you're going to be significantly at risk. I know we were contacted quite often to try and help with mediation for family, and Charlotte brought that up early on at the beginning of this discussion. That's something we got involved with. Is that an area that is still an issue for patients at the moment? Are we, issues around isolation, both for those that are isolated at home and those that are isolated without family? Are you able to help in those areas?
Is that question?
Was that for you, Charlotte, or me?
Both of you.
I can jump in if you like. So I think it's fair to say, Ella, that was something we saw more of in terms of being unable to have visitors in hospital sort of 6 months ago. I think it's becoming less of an issue as the rules around visitation have been broadly, as far as I'm aware, relaxed slightly. In terms of isolation at home, that is an extra challenge that we've not, I guess, practically there isn't much support at the moment. I guess you're alluding to things like being able to visit the GP surgery when there's fewer people around, Nick, those sorts of things, in which case we would be able to help you to express what you need to the GP surgery if you were struggling with that. Same with, I don't know, opticians, dentists. I'm just coming up with various places where you may need to go where you may feel unsafe as a leukemia patient at present. And if that is something people feel they need support with, we'd be more than happy to sort of help you work out. It's similar to a complaint. If you need help articulating what you need, regardless of who you want to articulate that need for, we're there to help. And I'm getting overexcited now and I need to stop flailing around. Sorry, everyone.
That's great. And I did have a second question, which I think Ella's already answered. What's the most frequent topics and challenges that patients are seeking advocate advice on today? And I think that's around COVID and COVID safety and efficacy of vaccines, availability of vaccines. Anything to add to there before we move on, maybe into discussing some of what I often call the dark arts of advocacy in terms of policy and from advocacy into policy and influence? Anything to add?
I think there's one question in the chat box, literally a practical question about whether you can access antibody tests entitlements. We might as well answer that since we're here. So someone's asked essentially if you can ask for tests to determine your immunity from COVID. The answer is you're not entitled to that on the NHS. If you feel like something you need clinically, for any reason, please speak to a haematology team about it. They are able to recommend those things for you, but it's not something that is the government's made available to everyone, a leukemia patient or otherwise at present. Just thought I might as well answer that since the person is here.
Depending on the disease as well, it's part of routine practice that they actually, the consultant will monitor your immune capabilities. So that's the route to go to, I agree.
Yeah, absolutely.
You can also look at the private route with regards to antibody testing, but that would mean paying for them and going down a different provider. And there's various things to be aware of when you're doing that, making sure that you're able to interpret the results that you do get via that route with your consultant or your GP or whoever it is, being one of the most important ones.
Yeah,
good point.
Antibody response doesn't just mean capability, and you shouldn't be changing your lifestyle or your risk assessments just purely based upon that. I think we're all going to get a lot more information, aren't we, as the data matures, and that is maturing now. Where we go from here is, I think really is follow the website, follow the regular blogs. We're keeping these updated, you know, on a day-to-day, if not day-to-day, a week-to-week basis. Use the toolkits. There are advocacy toolkits on the website that people might find of value that will help with navigating a lot of what we've been talking about. I'm mindful of time, and I'm also mindful that I can't see very much now that I've lost my large screen. So apologies everybody for this. I've got a nice large screen in the run up to Christmas to make sure that I could see everything, because I haven't been able to see anything, and I'm a bit of a Luddite, and when first webinar I come to, and it didn't quite work the way I planned it to. Ella, how about talking about advocacy from a policy end?
Yeah.
Maybe you could allude how we as advocates get involved in campaigning and access and other areas of influence.
Yeah, definitely. I think, as you said, Nick, this tends to be the more mystical side of what we do. We at Leukemia Care do something called evidence-based advocacy, and we also then do evidence-based policy. And I guess what that means is that we need the information from patients, and we use that information. So whatever it is that, you know, general issues that people are making us aware of, or areas where we think need lobbying or campaigning or change within the system, we can use that as an evidence base, obviously maintaining patient confidentiality, and lobby for it, or think about ways in which we can lobby for it, whether it's through big campaigns that we do. You know, like, for example, we've launched in the campaign, the Life versus Livelihood, in the pandemic, the Life versus Livelihood campaign, which was around employment and immunosuppressed patients, and the sort of unease between restrictions lifting, having to go back to work, employers, you know, not necessarily offering those reasonable adjustments, or perhaps patients have jobs where those reasonable adjustments can't be implemented. Maybe they work in hospitality or in the arts, and just, you know, we launched a campaign about the issues that they're facing in terms of having to put their health on the line in order to save their livelihood, and those types of things. And so that's when we would engage with stakeholders like the government, for example, the NHS, whoever's relevant for the particular issue. We have contacts with MPs and House of Lords, so sometimes we can get them to write letters on our behalf to ministers and secretaries of state, and that can be as part of a campaign, or it can be a separate initiative that we just, you know, maintain those ongoing discussions. But all of it, just to come back to the evidence base, all of it is, and I think how policy should be done, is based on what patients are really facing. So what issues you're really struggling with on the ground. And I think that forms the basis for a lot of our policy work, as it should. And that comes through not just obviously advocacy and conversations with patients, but through things like our patient panel, which I can touch a bit more on if you need to. And then also things like surveys are another big way that we gather that information. I know there's a lot of surveys that patients probably feel that they get thrown at them, but surveys is one of the ways that we're really able to gather that qualitative and quantitative information, which can really help start to form the basis for our campaigns and our ideas and our plans and actions. Yeah, I hope that kind of explains the link, at least, between the two.
It's a good insight from that point of view, that, you know, as the clinical community, if there's no evidence, if the papers aren't published, it doesn't exist, and patients are fully aware of that when living with issues and symptoms. If there's no evidence collection in that area, then we get no mileage moving forward to aid recognition of addressing these needs. So it all comes down to evidence based advocacy, doesn't it, and making sure that we're driven by that. I guess that leads us on to another area of how that evidence is used, in terms of, you touched on it earlier, Charlotte, with regards to NICE for England access to drugs, and the SMC, the Scottish Medicines Consortium in Wales, the All Wales Medicines, AWSMG, that's another massive acronym. But so how do advocates influence new drug development, both in the clinical trial stage. So that's pre data maturing on clinical trials to make sure that the patient, that the information or the address or the trials are addressing things that are meaningful to patients. And then how do advocates also get involved in actually the process with the appraisal bodies to make these drugs available? And again, I'm picking up from that. A lot of this leads from the surveys and why these surveys are so important and why patient inputs are so important.
Yeah, I can touch on the clinical trial side of things. So we're lucky in that we get many researchers coming to us, and we're involved on bodies that make decisions on what clinical trials are going to go ahead, which gives us a really good opportunity to look at the protocols, or even before you get to a clinical trial is going to take place, what clinical trials are needed. We often get asked that as well. And Ella's already described that it's really important that we use the experience of patients to inform that. It's not about pursuing research for the sake of research. Our job as advocates at Leukaemia Care is to look at where the gaps are for patients. So I don't know, it could be there is no oral treatment for CLL. There is, but hypothetically, if there wasn't, that might be something that we would put forward. There is no, the current treatments for AML are not sufficient to cure people. There are instances in AML where that is true, especially if you can't have intensive chemotherapy. So we collect evidence on patient needs through our advocacy casework, through our surveys, through everything Ella's and you have already described. And we have routes in which we can feed that back to those doing clinical trials. But I'll leave the the nice stuff to Ella, because Ella's been working with patients very recently on that. So I'll let Ella do that bit.
Yeah, so I'll speak about NICE mostly. As Nick said, there are different counterparts in different of the devolved nations that do very similar things. But just for the sake of argument, I'll speak mostly about NICE. We have links with NICE, and we get asked to, for relevant, so when it's a leukemia treatment being appraised, we get asked to provide the sort of be a patient expert, as it were, in that process. And we do that by finding patients who perhaps have already had that treatment, whether it was on a clinical trial, and speaking to them about their experience of that. And we even use quotes and things like that in our submission to really kind of get across what that experience of that treatment has been for that patient. And in a lot of cases, we tend to find the gap for a treatment. So if we think a treatment is needed for a certain group of people within the indication that it's being approved in, then we will often recommend that is approved if it benefits patients. If it doesn't, then obviously we wouldn't, but most times we put forward a drug and recommend it. And then as that goes through the process of NICE, we can be involved in further consultation stages where sometimes we're able to bring a patient with us to speak to NICE and to the committee about their experience of the drug. So it's really our role to provide the patient voice, and I think it's a really important part of NICE, and something we do as and when the drugs go through the process, as well as obviously SMC and in Wales and Northern Ireland as well.
Thank you. I think it's interesting, isn't it, the amount of areas that advocates do get involved in addressing unmet needs, and I think it relies very heavily on our patients, all of you in the audience, maintaining engagement with the charity at all levels, so that we can carry that evidence and that information and your needs forward. So don't be frightened to step up in any areas, be it for wishing to get involved to help with the ad boards, advisory boards, or share your own issues that you have. And just want to finish on this section before doing some ending slides, which was really, you can't do it alone, and charities can't do it alone. And so I think, what's the significance and the importance of how do we as a charity and a group of advocates work with other advocates, just to share with everybody the importance of collaborative work and what level of collaborative work we undertake, and how do we lobby for change, and how do we measure that? Is that too difficult a question? It's a difficult one.
You've left us 4 minutes to talk about how you evaluate the impact of policy, which is a massive challenge.
Yeah.
Thanks, Nick.
Yeah, I'm sorry about that. Okay.
No, that's fine. Absolutely fine.
That's part of the dark arts, isn't it?
Yeah.
Mhm.
Ella, did you want to say anything? Otherwise,
I was summarising around in collaborative initiatives.
Yeah.
Really important.
Yeah, on the point of collaboration, we collaborate with other charities as part of, groups and alliances, which is important. So we're a member of Cancer 52, which is a group for rare and less common cancers. There's lots of charities that are part of that group, and they're able to have, particular meetings, for example, with the NHS, where they share, joint and also specific needs of the members. So, rare and less common cancers that include blood cancer. And then we also part of the Blood Cancer Alliance. They've just launched a new campaign called The Forgotten Fifth. But doing that collaborative work with other charities is particularly can help to kind of like diversify and intensify our impact and approach to stakeholders. So yeah, I'd say collaboration is really important. And we also attend, in terms of like how we lobby and keeping up to date with things that are going on. Charlotte mentioned research quite a lot. We also attend lots of conferences, whether it's that's on a global scale. So the American Society of Hematology Conference is coming up this month, I believe, and there's various different ones for different blood cancers as well. We often go to those and speak with clinical groups as well. We have lots of clinical contacts in terms of collaboration. That's also really important relationships that we have and maintain. Yes, Nick's kind of responsible for maintaining the relationships with the clinical side of things. So perhaps I can point the question back at you. But no, just to answer the more how do we lobby for change? It's a good question. I'm continually thinking about that, if I'm really honest. It's a big question. I mean, if I knew the answer, then everything would be hopefully resolved in a day or two, and we wouldn't be here in our roles. So yes, it's not a simple fix at all, but there are various things we can do, and I think, as you mentioned, Nick, collaboration is really important in that.
There was one actually in the area of access to new drugs, and you work with NICE and SMC and everything else. I noticed the last few submissions that those have been collaborative submissions across charities, for example, just to maximise impact.
Make it clear we're all on the same page is really, really important. And as Ella said, amplify one voice works better than multiple people saying slightly different things usually. And
sharing resources where we're strong, others are weak, and that we can step in to help the others, and vice versa. And I think that's a really good note to end. I'm just going to click share a few slides, and hopefully I can get it to work. And as I run through the slides, I'd just like to thank everybody for still hanging in and staying and being with us. And I've got to thank you, Charlotte and Ella, for providing all the information. I've not, if not learnt a lot, I've remembered a lot. And I hope everybody else has. And I think I hope people have got the confidence to understand that there's quite an extensive advocacy team at Leukaemia Care, as well as all of the support service resource and everything else. And that advocacy is always a good place to start from sometimes if you're unsure of where to go, if you've got issues, as a point for at least signposting from if not to step up and actually help advocate on your behalf with you. Don't be alone. Don't feel that you've got nowhere to go in that respect. Reach out. That would be my parting message. On that note, I'm going to share a few end slides. If I can get them to go, fingers crossed. Nothing happened, no.
We've got the PowerPoint.
There we go.
Perfect.
So just to remind everybody, those that haven't joined our webinars before, we do provide as a charity quite a range of information and supported resources. Webinars you're on at the moment, but we have actually there's a new newsletter magazine that's just come out for Christmas. I don't know if it's been published yet, but it will do. Well worth a read. Great at the end of the year to actually have a look back over the year and forwards. Charlotte runs a series of podcasts. I think you've actually captured me on one that's coming up fairly soon. Hope I don't bore you all to death, but there's a great library there of previous information being shared by patients and everybody else. Very active on social media. Keep up with us on Twitter, Facebook, Instagram. Now the website is pretty extensive. Please use it. We've extended the comms team and the resources to keep you all up to date. Booklets. I don't know if you all know, we do have an extensive range of information booklets that cover all of the disease indications and some of the peculiarities of living with leukemia. Well worth a visit and having a scan through there. And you can just download a PDF and access what you need. Support services are fairly extensive. We have a helpline that's staffed by clinical nurse specialists as well as the support team. There's an instant WhatsApp service if you want to correct directly. We've got a national network of virtual support groups across all of the different disease indications and regional and offering different aspects. Always worth a look if you want to connect with other patients. That's mainly peer to support. As a patient myself, that was the greatest eureka moment for myself, is being able to share issues that you can't with others. Even sometimes you might find it hard to share with the staff at Leukaemia Care. A lot easier was through support groups where you're talking to fellow patients. Lisa, who can join us today, well worth talking to if you've got issues. I noticed somebody posted a post within the thread that was about PIP and welfare and entitlements. Please do get in touch with us. I'll come on to the slide details in a minute and take it up with Lisa. She can look at that with you and maybe help address that. Advocacy support, we've just bored you to death talking about. I hope you've taken some of what we said on. We've obviously got the Facebook and online forums, and most importantly, Charlotte mentioned earlier, that can be really helpful again is buddy schemes. That's often quite a great way of trying to, a buddy scheme is a form of advocating. It's other patients advocating for you and helping hold your hand through the learning process and sharing mutual issues. That's often a way of preventing breakdowns and sharing thoughts to help progress potential issues. Emotional, psychological challenges. Well, we're all pretty aware of these at the moment. We were aware of them as patients. If we weren't before, we're certainly aware of them COVID. Worth getting in touch with the charity. The charity does offer a counselling fund. It's the end of the year. That's being renewed, starting again fresh from January. Still a bit of a waiting list, but if that's something you're looking for, well worth getting in touch with us now and put your name down if you feel that you benefit from contact with a counsellor to be able to air issues that you've been carrying as a burden for yourself. Okay, our advocacy caseworker. Well, I guess that's you. And if you want to get in touch with Ella, if you want to talk about issues with Ella, this slide will come up on the video and be fully available with you, but there is the address to get. You could also get in touch through support. Either way, you'll get to the right people. Again, thank you for the person in the audience for posting the question around welfare. There's also the address and phone number to be able to get in touch with our welfare officer if you've got issues. And I think that is quite a predominant issue. If we look at services in advocacy at the moment, we're quite top heavy in welfare questions and welfare requests for help at the moment. I think the pandemic's played a very large part in that. So next webinar, for those end-of-life care, understanding end-of-life care. It's not something that we all talk about as patients. It's not something that a lot of charities talk about. They often put this at the back of the filing cabinet. I think it's really important that everybody can get an insight of understanding end-of-life, because life does come to an end for everybody. It's important that you know where the information is, so that when you need to reach out for it and if you need to plan ahead, that you can do. So it's not a negative topic, it's an important topic. And the majority of leukemia patients, adult leukemia patients, are older people. It's a good idea to understand where you have to go. And that's a key area that the advocacy team can work with you and your family should things go wrong and the wheels fall off the bus in the future. You can keep up with all our latest news and patient stories using our social media channels. As I said earlier, very active, a very active Twitter, very active communications group. We've just expanded that. Please use the services. And I'll leave this up for the end here for support and information. So you've got it in front of you. Free phone helpline. Give it a call. You'll always get through to the right person. And or alternatively, use the email. I'd just like to thank our advocacy team. It's great to be able to be on this side of the screen and be on the screen with you. And thank you everybody for joining us. And don't do it alone. Yeah, Christmas is coming. Okay, you feel you've got problems, you've got issues. If you've got things that you feel are insurmountable, and reach out to either the care team or the advocacy team, and we'll do our best to help you. Thank you, everybody.
Thanks, Nick.
Thank you.
Bye, everyone.
Bye.